Lily. I'm going to be your respiratory therapist today. How are you feeling?
Good.
Good.
Well, not too good,
well,
actually.
not too good. Yeah, I would imagine it's not easy being in the hospital.
Yeah.
Well, like I said, I'm Lily. I'm going to be your respiratory therapist today. I see the doctor has ordered me at bedside to be able to give you some oxygen therapy. We're going to go ahead and go through that here in just a moment, but it shouldn't take more than maybe like 10, 15 minutes at the most for me to do all these interventions with you. And I'll tell you what I'm going to give you here in just a moment. I'm kind of saving a space to give the explanation part of the AIDIT once it's actually time to implement the therapy. Alternatively, your narrative could look something like this, where now you've identified whether or not you have an order. Then I'll come over to the table, put on my gloves and stuff. I'll say, hi, Mr. Lennon. I'm Lily. I'm going to be a respiratory therapist. Looks like the doctor ordered something called oxygen therapy for you today. Is it okay if we go ahead and implement that with you today? Yes, of course, thank you. Well, before I get too busy giving you this therapy, can I verify your name, date of birth? And he's going to give me that verbal response of John. The instructor's going to say John Lennon, date of birth 10/9/1940. Great, thank you so much. Can I come and check your wristband? And I'm going to want to see that you're doing that as well, that you're verifying all three components for patient identification. They're not going to know. Patients don't know their MRNs, but I do need to hear that you're verbally confirming name and date of birth, and that you physically check the wristband for that information and correlate it back to the information in front of you. So I've offered them my acknowledgement of them. I've introduced myself. I've given them some space of what that duration looks like. And I haven't given the explanation yet, but you can when it comes time to actually deliver the therapy, or you can come in and already have that decision. Maybe as you're looking at this, you've made a decision. I wanted to hold back on it to see if you guys made a decision on what you want to offer for this one. What do you guys think?
Nasal cannula.
You want me like nasal cannula? Is everyone team nasal cannula?
Ventimask.
Why?
COPD.
Okay.
Need precise O2.
Okay. Who's team nasal cannula? Who's team Ventimask? Oh, we're all like brave. Well, who's team? I don't know. Nasal cannula or Ventimask are perfectly fine. This is where a little bit of subjective, your own responses come into play. I'm going to expect some justification. I can't tell you which one is going to be the best. I look at something like this and I see history of COPD with a mild SpO2 of 86%. I'd probably be leaning towards nasal cannula too. I'm right there with you guys. But I see the word COPD. I'm like, they have a history of COPD. Maybe to be extra cautious, I can see that you would make that decision. So I'm not going to fault you for either of those choices. But do you see how maybe choosing a simple mask, I'd be like, meh. And then I'll mark your points off for that. But between those two, you can justify to me your reason for that. And I'm going to hear your justification and how you educate your patient on there. So if you made that decision on nasal cannula, your education might look something like this. All right, Mr. Lennon, so the doctor called me into bedside to give you some oxygen therapy. I brought in something called a nasal cannula because the nasal cannula is something that gives kind of like this low flow. I'm looking at your values. Looks like your numbers aren't too bad, so we're going to give you something that should be pretty easy to use since you're not in a very exacerbated state. Looks like you're pretty stable right now, which is true. All right, Mr. Lennon, I'm Lillian of your RT. I'm coming in to give you some oxygen therapy. I've decided to give you something called an air entrainment mask. I am a little concerned about you having something called COPD, and because of you having that, I want to make sure that we're giving you the precise amount of oxygen necessary in case of you having any issues with that COPD. So I'll teach you a little bit more about this air entrainment mask as we go through it. Also true, right? So it's a gray zone. I can't say one is going to be right over the other, but there are some devices that's just completely inappropriate to give, like a non-rebreather or the simple mask or the oxidizer, and that may not be the best choices, do you see? Mm-hmm. So you're gonna guide me through that part two, that narrative. You're gonna say, hi, my name is, the introduction, acknowledging your patient, how are you feeling? I'm so sorry to hear that. You're gonna give them the duration. I won't be in here more than about maybe 5-10 minutes. If you've already made a decision about what you wanna give, at this point you can start beginning the conversation on what that explanation looks like. And then before I get too busy actually giving you this therapy, let me make sure I verify your name and date of birth. Cool, let me check your wristband. Wonderful, all good to go. Before I get too busy actually giving you this therapy, I really need them to check those vitals before I do anything, because that's important. Before you do anything with your patient, check your vitals. So that's us leading into the part 3, ultimately. Where now I'm gonna watch you, how do you do those vitals? So at this point, it's going to be necessary that you have your pulse oximeter with you and your stethoscope around your neck for competency number 2. So how to check the vitals? We remember this from week 1, or do we need a little review on how to do this? A little review, maybe? Or remember?
Sure, go for it.
Why not?
The review that is going to be for assessment of vitals. So I don't have that stethoscope I can borrow. That's my time to bring mine and just leave it in here. I'll leave it in my office. Thank you. Come on, Victorville, home. So you'll have your stethoscope, you'll have your pen that can help make these notations. You're gonna be checking the vitals on me, so I'll be coming up to my patient. My tactics for checking vitals are as follows. I like to get my pulse ox first, make sure my patient can rest their hand on the table, because it takes a moment for this thing to load. So while the pulse oximeter is loading, that's when I like to come and check my breath sounds. Breath sounds assessments are gonna be 6 in the front, 6 in the back. So I'll come to David, I take hand on, you're good. I'll take hand to clavicle to see where I can orient my breath sounds assessment. Because clavicles, remember they kind of lift up just a little bit above that space, so I'll come right beneath it to begin my initial assessment. So there's one assessment here, deep breath in and out. And then 1, 2, 3, 4, 5, and 6, since this is a male patient. If it was me, I'm gonna ask you guys to 1, 2, 3, 4, 5, and 6 off to this side. And then the back, same thing. There is the the scapula here. So I like to try to stay towards the center. 2, 3, 4, and then once you're past that space, you can kind of come off to the side 5 and 6. It's really about where you can comfortably hear your breath sounds, and then you're gonna come and make notation about what you heard. What you're gonna hear on me is probably clear breath sounds. I'll say, okay, let's pretend like I was wheezing, and then you'll make note of wheezing potentially. Question?
Yeah, are we looking for the certain bone right here, just for the auscultation?
I'm looking for kind of a swooping motion to kind of avoid it, but if you can tell me that you heard it, then I'm gonna trust that you heard it. But it's more about practice trying to find the spot that you can hear. Because just be honest with yourself. If you feel like you're not hearing it, let me guide you. Let me see if maybe we press it here, or just practice with each other. You got to start figuring out where am I going to hear it. And honestly, all of us, we're pretty clear. It's not going to be the easiest thing to get information from each other. You'll start to get really fine-tuned in how you can find those breath sounds when you start hearing actually wheezy or ronchi or crackly patients.
Say if we're auscultating your lungs, right? And of course yours should be normal. But say if we don't hear something, would we get points marked off if we let you know, like, I can't hear any breath sounds?
No, that's
Because
fine.
we're not.
More where you might get points deducted for the breath sound assessment part is if you're doing breath sounds. Okay, let me check for your breath sounds, and it's like down at the stomach or something, right? Or if I'm over here and he's like way over down here, it's like down at the waist area. I'm like, do you know where the lungs are? The lungs are at the breast line and up, really. Much lower than that, you're not actually hearing breath sounds. So I might kind of guide you, and especially this first patient assessment based scenario, competency, we can have bigger conversations about like, hey, like we're actually like one-on-one right now, you're not doing it right, and we'll talk about it. So there might be space for point deduction, but it's not gonna be like an end of the world thing. It's like, you need to just do it right. Let's talk about how you might not be doing it right now. So at that point, I'll have just checked the breath sounds. I'll come to my documentation and write down what Miss Bernier whispers to me. Let's pretend I'm actually wheezy right now. Then I'm gonna come to my pulse oximeter, see that he's setting 96%. I'll say, okay, I see that the pulse ox is 96. Let's pretend like I'm setting like 86% like the scenario says. But it's your intent to now read the pulse oximeter and remember that the pulse ox is demonstrating information that you don't necessarily trust. So at this point, I wanna make sure that you are correlating the information on the pulse ox. So I'll have the patient flip their wrist over so I can get a manual pulse check. So I'll find the pulse. I'll try the other hand since your watch is on. Find pulse at the same line as the thumb. And then at that point, once you find pulse, I would recommend having your timekeeping device on and count or find a space to monitor that 15-second interval. So now I'm at that 15 second. So I think I got a little under 20. I'm gonna say that was 19. So not 20, so that's not 20, 40, 60, 80, that's 76. I looked down at his pulse oximeter, it says 73. That's correlated. Pat on the back for me. That's what I wanna see from you guys. It's reading 76, 77 right now. That means whatever I'm feeling, it's matching on the machine here. Obviously, if you're getting 60 and my pulse oximeter is reading 90, then I'm gonna be like, let's try that again. I always have my Apple Watch to kind of correlate because I trust the device pretty easily to match against what you're doing. So it's a matter of me just trying to see that, are you able to do that correlation tactic effectively? So there is gonna be a little bit of check off against the machine itself, which I know we're doing with the intent of checking the machine, but this is kind of a way of me seeing, are you checking in the right spot? Do you have a good feel for it? A lot of times the students will come in and they press way too hard. If you are pressing way too hard, you're literally occluding the vessel in that instance, so you might not be able to feel anything at all. Or you're hovering too lightly and you can't feel anything. So we can have a discussion on how to do that optimally, but hopefully you're optimizing that tactic so you're hopefully not losing points on competency day. So you'll have correlated the information. So now at this point, you have obtained breath sounds, you've obtained a saturation, and you've obtained a heart rate that you trust. At this point, a student always likes to ask, do I use the number that I got or the number on the machine? It doesn't matter. If they're correlating, then both numbers are pretty trustable. So you'll mark the value that is pertinent to your comfort. And then at that point, the value that is missing is the respirations and the sputum. Remember, for respirations, my tactic is, let me try that one more time. And then instead of feeling for a pulse, you're just gonna bring attention to the chest rise and fall and count how many times your patient is breathing in that 15-second interval. Alternatively, I always kind of just get in the habit of teaching it like this, but I know you guys are smart and I know you guys can keep more than a couple of numbers in your head. So one way of going about the whole thing is pulse oximeter on, breath sounds, come to do the heart rate check, and while you're doing heart rate, you'll have noted, okay, that's 19. And then just kind of simultaneously, so it's like a 30-second check ultimately, so you're just doing bang, bang, the same thing. You don't have to pause. If you can hold both numbers in your head comfortably, do that. If you can't, do that, kind of pause and documentation is necessary.
Ms. Bryn.
Yeah.
I know we don't really want to tell them that we're trying to see their respiratory rate, so we do another pulse check. If they think you're checking their pulse, would it be considered inappropriate to look at their chest? Like if it's
now you're like putting on sunglasses.
Is there like another method perhaps?
You know what? I'm being silly because now I'm just reminded of a colleague that said, this is how I check breath sounds, and then he like put on a stethoscope and then eyes direct on the patient. Like everything that we do is not direct eye contact anyways. So I think the best way to answer your question, because it is like a logistical thing, right? You're gonna come over here, and then when I'm counting, I can kind of look off to the side as if I'm trying to, did I find it? Did I find the pulse? Oh yeah, I think I found it. And then kind of just like keep your orientation there. So I don't know if that's helpful. I'm kind of thinking something like that, but I see where you're coming from, like what logistically would be helpful.
Can I add one to that one?
Yeah.
When you're taking them from, when you're listening to lung sounds,
Yeah.
you can just like, okay, just breathe normally for a bit for me. And then you just count the respirations from the back as the,
Oh, while you're doing breath sounds.
yeah,
Mm-hmm.
and rise.
My issue with that, I do like that advice, but sometimes I feel that when I'm doing the breath sounds part, they modify entirely to be like they're doing something on purpose so
You
I
tell
can
them,
hear
breathe
better.
normally right now.
Yeah, so remind them to breathe normally, but telling them to breathe normally
You're right.
might not be emulative of what they
You're right,
maybe
yeah.
normally would be doing, if that makes sense. So anyways, it's no skin off my back. Ultimately, guys, I just want to make sure that you're